Firstly, I'd like to thank CESPN for organising this webinar and all of you for coming tonight. I too wish to acknowledge the traditional owners of the land that I'm sitting on, which is Gadigal land. So as you're aware, COVID is still in our community, and in the Canterbury area, we've continued to see recent transmission in schools and households. We know that when we work together, we're at our strongest. And the last time we met is in July to discuss the Delta outbreak, and many of you would have attended that webinar. And the community vaccination rollout, we found great solutions from all of you, and it was through the community and yourselves that we enacted those solutions. We're in another critical time, and this is in our response to COVID as restrictions ease. You would have all heard there was 403 today across New South Wales positive cases. So this includes our unvaccinated people also from December 15th, and a new variant has emerged. And of course, with the rollout of the paediatric vaccinations for children that are aged 5 to 11 years, which is going to commence in January. We'd like to improve the vaccination rate in the 12 to 15 years age group in Canterbury and maximise the uptake in the 5 to 11 age group in the lead up to the school year resuming next year. We've been working with our local schools and we've found that community leaders and organisations have had some great ideas, and Dr. Teresa Anderson and community leaders have been meeting recently and having various discussions about how to inform the Canterbury Action Plan and also in particular the youth vaccination plan. We know there's difficulties in getting to those people who are reluctant, and we've found that they're one of the most difficult to find solutions to get vaccinated. So we need your help. GPs and pharmacists continue to play a crucial role in keeping our communities safe, and we need to keep working together to encourage testing, vaccination and boosters. So tonight's webinar, which was an idea of the community leaders last week and various GPs that joined that discussion with Dr. Teresa Anderson, is an opportunity to hear about the current COVID situation in Canterbury, but also to discuss how we can work together to keep the Canterbury community safe. So here with us today, as you heard Brendan say, is Dr. Karen Chi. So thank you, Karen, for joining us. And Karen is our staff specialist in the or one of our staff specialists in the Sydney Local Health District Public Health Unit. And Karen's going to give us an update on COVID transmission and vaccination rates. So thank you very much, Karen. Over to you.
Great. Thank you, Luanne. Thank you, everyone, for attending. We know you're all very, very busy, so thank you so much for your time. Just going to share my screen. Okay. So I'd also like to acknowledge the traditional custodians of the various lands in which we work today, and the Aboriginal and Torres Strait Islander peoples participating in this webinar. I pay my respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. So once again, thank you for the opportunity to present today. My name's Karen Chi. I'm one of the public health physicians in the Sydney Local Health District Public Health Unit. And tonight I'll be presenting or providing an update on the COVID case numbers and also our vaccination rates in the Canterbury Bankstown local government area, with an emphasis on our children. So just as context, our COVID case numbers and vaccination rates are routinely reported for local government areas, and that's why it's Canterbury Bankstown local government area, noting that the Canterbury portion of the LGA lies in Sydney Local Health District, and that's the portion of the map circled in blue or outlined in blue, and the southwestern Sydney LHD portion of the Canterbury Bankstown LGA is the rest. And this map shows us what the Sydney Local Health District actually comprises of, the various councils. So Canterbury Bankstown Council lies at the southwest portion, and it borders obviously various council areas in southwestern Sydney LHD, but in the Sydney Local Health District, it also borders South Strathfield, Burwood, and the Inner West Council. So if we have a look at this slide, it shows the number of cases in the Canterbury Bankstown local government area since this current Delta wave, which started on the 15th of June. So it's been going on for almost 6 months now, and still continuing. And since this current Delta cluster began in mid-June, we have had 83,383 cases notified in New South Wales. And around 15% of those total cases in New South Wales are actually in residents in the Canterbury Bankstown LGA. And of those 12,000 over cases, 36% of those cases are actually in the Canterbury portion of this LGA. This table shows the top 20 metropolitan LGAs with the most number of cases. And unfortunately, Canterbury Bankstown LGA has the most number of cases during this current Delta wave. And this trend continues in the last 7 days. So if you have a look at the most right-hand side table, we've had 148 cases notified in the last seven days on average. And that's the highest in terms of absolute numbers. In terms of the age distribution of the total cases in New South Wales, children aged between 0 to 9 years old and 10 to 19-year-olds account for the third and fourth largest groups after the younger adults aged between 20 to 39-year-olds. And if you combine all the children, so aged between 0 to, I guess, 18-year-olds, they actually form the largest percentage of cases in New South Wales. And in the Canterbury Bankstown LGA, children also account for a substantial percentage of cases. So in the last 14 days, of the 158 cases in Canterbury Bankstown LGA who live in Sydney Local Health District, just under 50% are aged 0 to 18-year-olds. And if you compare this with neighbouring LGAs for the same time period, who've had 71 cases, say in the Inner West LGA, only 17% of those cases are aged between 0 to 18-year-olds. And if we look at the cases which are associated with schools, since schools reopened in term 4 on the 25th of October, 85 cases in students and staff have been linked to 15 schools in the Sydney Local Health District part of Canterbury Bankstown LGA. And notably, Lakemba Public School has had 31 cases in students and staff, and an additional 40 cases in their close contact. So 40 cases who haven't attended their schools, but who've become cases as a result of the exposure to students or staff. And in comparison, if we look at the Inner West LGA, there were 35 cases in students or staff associated with 12 schools in the Inner West LGA. This slide basically shows very clearly that it's the unvaccinated who are at greater risk of acquiring COVID and also of experiencing more severe disease, which requires hospitalization and ICU admission, and also, unfortunately, of death. So far, we've established that the absolute number of COVID cases are highest in the Canterbury Bankstown LGA, and that children aged between 0 to 18 years account for just under half of all cases in the SLHD portion of this LGA. Fortunately, COVID is generally a milder disease in children compared to adults, with up to 98% of children either experiencing mild or no symptoms. Since 16th of June this year, children aged 0 to 11 years who are ineligible for vaccination account for 20% of cases in New South Wales, but only 5% of hospitalizations, 0.8% of ICU admissions, and no death. There has been one death in a child aged, in an older child aged between 12 to 16-year-old, and they had comorbidities. So we do know that some children, especially those of underlying medical conditions, have a greater risk of developing severe disease. And the most important conditions would be type 1 diabetes, obesity, asthma, those with chronic congenital cardiorespiratory conditions, and those children with any sort of immunocompromising conditions. But any child who does get COVID is also at risk of developing sort of later complications, such as the multi-system inflammatory disease and possibly long COVID. So in terms of multi-system inflammatory disease, we've had 26 cases reported in Australia, so across Australia, and 38% of those cases are in children aged between 5 to 11 years old. So we don't know which children are at higher risk of developing multi-system inflammatory disease. We're still trying to work that out. But these children, if they do get that, do have, I guess, sequelae, inflammatory conditions affecting various organs. And but fortunately, most of them do recover within 12 weeks. So by vaccinating children, we are protecting them against severe illness, especially the ones who have vulnerable comorbidities. But importantly, we are also protecting or benefiting from collecting benefits. So we're preventing or reducing the transmission of COVID from children to other children and adults, especially where extended family live together or where older relatives care for the younger children. And we know that to be a common occurrence in our LGA. But importantly, we're also reducing disruptions to their schooling and other learning and socialization and impacts on their mental health. When children go to school, they don't only learn. Some of them also obtain nutrition when they're at school through breakfast clubs. And we know that education is an important I guess, aspect of alleviation of financial hardship, maybe not now, but definitely in the longer term. And unfortunately, it's the vulnerable children who are at greater risk of having a negative impact if their school is disrupted. So it's important that we do vaccinate children so that the vulnerable children can continue to participate in social and educational activities with their peers. Obviously, we also, by reducing the transmission, we also reduce the impact on parents and other family members from having to isolate as close contacts, which obviously impacts on their ability to work and on financial hardship. So currently in Australia, children aged 12 years and upwards can be vaccinated against COVID. And children 12 years or older are recommended to receive 2 doses of either the Pfizer vaccine or the Moderna vaccine. The dose used is the same for older teenagers as for adults. The 2 doses of the Pfizer vaccine are given 3 weeks apart, and the 2 doses of the Moderna vaccine are given 4 to 6 weeks apart. And over the weekend, as you would have all heard, Pfizer was provisionally approved for use in children aged between 5 to 11 years, meaning that TGA has evaluated the efficacy and safety of the vaccine. And importantly, once it does come out, when you're speaking with parents, it's reassuring to note that there haven't been any safety signals from the US, who have vaccinated around 5 million children so far in that age group. The dose of the Pfizer vaccine for children aged between 5 to 11 is a third the adult dose, so it's 10 micrograms. So the next stage is to wait for ATAGI's recommendation on the vaccination program. So TGA does the approval when they've evaluated the efficacy and the safety of the vaccine, and it's ATAGI which then makes recommendations to the government or to the health minister as to the vaccination program. So who to vaccinate, whether that be all children or just children with comorbidities. And the interval between doses, whether that should be 3 weeks as for adults and adolescents, or whether it should be spaced further apart, and on booster doses. And all ATAGI's recommendations will depend on the epidemiology, the burden of disease in this particular age group. The hope and the plan is that once ATAGI makes their recommendations, children aged between 5 to 11 years can start being vaccinated from the 10th of January next year. So in terms of booster doses, a booster dose is currently available to anyone in Australia aged 18 years and over who's completed their primary course of vaccination at least 6 months ago. And in certain circumstances, the routine 6-month interval for booster doses may be shortened to 5 months. For example, if a patient's at greater risk of getting more severe COVID in an outbreak setting, or if they're traveling overseas and due to get their COVID booster soon. So the next slide basically shows the COVID vaccination rates by age group in this LGA. And unfortunately, in this LGA, the vaccination rates are lowest in the 12 to 15-year-old age group. So it's 67% for the first dose and 62% for the second dose. And the rates of the second dose vaccination in the 12 to 15-year-old age group are considerably lower in this LGA when compared with the Sydney Local Health District overall rate. So there's definitely room for improvement for this age group. And most other age groups are comparable to the SLHD overall rate. And in fact, for the 16 to 29-year-old age group, the rates for this LGA is actually higher than the overall SLHD rate. And unfortunately, if we go back to the previous slide, our vaccination rates haven't increased substantially for this LGA in the preceding 3 weeks. So it's important to remember that in addition to vaccinating children, the other means to prevent COVID infection or transmission include ensuring as many adults as possible are fully vaccinated, including administering boosters when they're due. We know that immunity wears off, especially in terms of immunity to getting COVID. So it's very important that when boosters are due, that adults and adolescents get it as soon as possible. The other measures to prevent transmission and infection in children include encouraging wearing masks whilst they're at school or outside when they're unable to social distance, practicing respiratory hygiene, social distancing, cohorting in schools, and staying away from school if they are unwell, and getting tested as soon as possible. I thought I'd just give a brief update on the use of the rapid antigen home test in schools. And this is in a bid to minimise disruption to schooling when cases have attended schools while they've been infectious. So from the 29th of November, New South Wales Health has approved the use of these kits as an option to get students from kindergarten and above back to face-to-face learning if they are identified as a close contact from an exposure at school. So this is not an option if a student is identified as a close contact outside of school. If this is an option and it's suitable for that school, then the Department of Education will work closely with the school and with the parents. And to participate in this program, students must first return a negative standard PCR, so a nose and throat swab test result. And if that's negative, they can then return to school as long as they use the daily RAT kit each morning before school for the next 7 days. Whilst this is going on, they still need to isolate at home for the 14 days from the date of their last exposure. So they can go to school, but they can't go outside into the community. If the RAT result is positive, then the student must go on to a formal swab and isolate while waiting for that result. If that formal swab result is negative, then they can resume this testing program and attend school. If the formal test result is positive, then they're treated as a case, obviously, and have to isolate as a case. And I thought also topical at the moment, just give you a brief update on the Omicron variant of concern. So the first known confirmed Omicron infection was from a specimen collected from a South African patient on the 9th of November this year. They reported it to the World Health Organization on the 24th of November. And since then, it's been reported in over 40 countries, including Australia. The World Health Organization declared Omicron to be a variant of concern on the 26th of November. And to be declared a variant of concern, the variant must be associated with one or more of the following changes. So either increase in transmissibility, increase in disease severity, either a decreased effectiveness of the available tests or that we use, or the vaccines that are therapeutics or public health measures that are currently being used. So the Omicron or B11529 variant is generating a lot of interest, mainly because it's on whole genome sequencing, the most heavily mutated variant to emerge so far. So it's got around 50 variants, and over 30 of those variants are in the spike protein, which is the target for our current vaccines. So at the current time, the world, including Australia, is still collecting information on those aspects of concern that are listed on the slide, so on transmissibility, severity, the impact on testing and vaccination. And over, I guess, in the next sort of two to 3 weeks, we should have more information, and that will dictate our public health measures. Sorry, it's getting on, so I might just move on to our summary. So in summary, across New South Wales, the highest absolute number of COVID-19 cases have been in the Canterbury, Bankstown local government area since the beginning of this Delta cluster in mid-June. Children aged 0 to 18 years account for around 50% of all cases in the Canterbury, Bankstown local government area. And many schools have been affected by COVID-19 in this LGA. The benefits of vaccinating children are not just for preventing severe disease in children, but also for preventing transmission to other children and to adults, reducing disruptions to their learning and socializing. And this is particularly important for vulnerable children. The lowest vaccination rates in the Canterbury Bankstown LGA have been in the 12 to 15-year-old age group, with only 67% of children having received their first dose and 62% having received the second dose. And unfortunately, these vaccination rates have not increased substantially in the preceding 3 weeks. So we're very much looking forward to engaging with our GPs to see how we can improve that. So thank you.
Great, thanks so much, Karen. Terrific presentation, and I'm sure we'll have lots of questions. So moving straight on to talk about vaccinations in children and young people today, we've got Professor Ian Caterson, who is the medical lead at the RPA COVID clinic, amongst many other things, many other hats that Ian wears. Thank you, Ian.
Thank you, Luann. And I too would like to start by acknowledging the traditional owners of the land. I'm on Gadigal land, and I'd like to pay my respects to elders past, present, and emerging. We've got some. Now, I, as some of you may know, am an endocrinologist by training and a professor of human nutrition. And for the last year, I've been running the vaccination service at Mallet Street, and I have enjoyed that and learned a lot. I thought we'd start by just reminding you of the biochemistry behind this vaccination. And the reason to talk about how this really elegant type of messenger RNA vaccine works. And just to remind you of it and the way it is fantastic. So remember a cell, just look at the screen, and up here is the nucleus, and the rest of is the cytoplasm, where the cell does its business, protein synthesis, detoxification, whatever. And what we're doing with this new vaccine is providing messenger RNA, which is just a chemical. So when you turn on a gene in the nucleus, you make messenger RNA, which is a sort of mirror image of the DNA of the gene, and that travels to the cytoplasm, goes to the ribosomes, and it's a message. And amino acids are brought up to that message on the ribosomes, and a protein is synthesized. And in this case, we're using the messenger RNA for the spike protein. Now, that's really good because we've heard about the Omicron variant with 32 changes to the spike protein. And using messenger RNA, it does mean that we can rapidly now make a newer vaccine to allow this particular spike protein to be part of the vaccine. So the way it works is messenger RNA in little fat globules is injected into the muscle of your arm, goes into the muscle cells, the messenger RNA. Your muscle cells make spike protein that is recognized as foreign. You make antibodies and killer cells against it. And that's the way you get immunity. And it really is effective. Once it's used, the messenger RNA is broken down and recycled for use in other messenger RNAs and has no other impact on anything else. I'm going to talk to you about COVID vaccination in children and adolescents because this is what's coming up for us. And why do it? Well, we've heard this earlier from Karen. There is, for the kids, protection against COVID infection itself. There is reduced severity, but for us, and I've heard this so often, in kids, it's only a mild disease, so why do they need to be vaccinated? It, for us as a community, reduces transmission and the COVID load. So it prevents families, older people in the community getting COVID. Now, let's talk about vaccination of children. And this is the trial, which was published just a little while ago in the New England Journal. And they randomized 2,285 children, and about 2/3 of them were assigned to receive the Pfizer vaccine, 10 micrograms, which is a third of the dose of the adult vaccine. And then 757 were assigned to placebo, and they followed them through, and 1,500 completed 1 month follow-up after dose 2, and 746 of the placebo. So yes, it did, worked well. Now, what did that happen? If you look at this, then what are the systemic events? So there's a whole range of things, and I'm sorry that you can't see the bottom, but about 40% of those, once they've had a vaccination, 30 to 40%, 34, 31, get some sort of systemic event. And there's a whole range of other things, muscle pain, joint pain, use of medications. And I'll try and move this so I can actually see what the others are, because I've got the control. There's headaches, chills, vomiting, diarrhea, and muscle pain. And this is much the same as it occurs in adults and after many other vaccinations. And this is for the first dose and for the second dose. So there are side effects, as they are with any vaccination, but they are not major. So what about effectiveness in children? So when we look at those who were vaccinated down here in the red, this is, I apologize for I keep getting the control bar in the way, so I can't see what's happening. So down here in the red is those who are vaccinated, and in a community in America where COVID is rampant, very few of them got it. But compared to those in the placebo, the cumulative incidence is much greater. And when we look at the surveillance time and the risk, then after the second dose, it is much reduced. What about adolescents and young adults? And again, we've been vaccinating these people for a while, and there are, again, systemic events and use of medication, fever, fatigue, headache, chills, and these occur at much the same rate. Interestingly enough, for those, they do feel tired and they get headache after the vaccination, but it is not a major long-term issue. What about the effectiveness in this? In the 12 to 15-year-old age group, it is more effective than in the 16 to 25-year-old age group. And when we look at the efficacy, it is 100% vaccine efficacy. So it really is a very effective vaccine against getting COVID. Now, one of the issues in young people we've heard about is myocarditis. So this is a study from Israel where they looked at several million people, healthcare workers, getting vaccines. And the estimated incidence of myocarditis was 2.13 cases per 100,000 people. The highest incidence was amongst male patients between the ages of 16 and 29. And in the children and younger adolescents, it was equivalent to that in the older adults. Most cases of myocarditis were mild or moderate in severity, and recovery was the outcome, though there was one case who presented in cardiogenic shock. Now, you're going to be getting this Pfizer vaccine for children in the next month, and it will come in a different vial with an orange top. and it is only a 10 microgram dose for children, and you're going to dilute it with 1.3 mils, give 0.2 mil dose, and each vial will give you 10 doses. So you're going to have to be a little bit careful in not mixing the vaccines for adults and children. And this will be one of the things that you need to think about as well. So, in summary, COVID vaccination for children is effective. It prevents infections in the children. It does reduce severity still. And for us in the broader community, it reduces the COVID load. There are side effects which tend to be the usual ones post-vaccination, but some of the more severe side effects are, such as myocarditis and pericarditis, are present, but they are low. They are not a reason not to vaccinate children. The COVID vaccine itself is a messenger RNA vaccine, which is effective, as we know, but it also, other than having acute side effects we know about, some rare side effects, does not affect any other aspect of our metabolism or genes. So I urge you to be enthusiastic in vaccinating children and adolescents over the next few months once this becomes available. We in the Sydney Local Health District will be running clinics for children, and there will be 5 major ones at Sydney Olympic Park, at our bigger community health centres, Croydon, Marrickville, Redfern, and I always forget the 4th one. And we will also be available to do pop-up clinics and flying squad clinics to other places. We do anticipate that most children will be vaccinated by you, the GPs in the district. And so it's really important that you're enthusiastic and encourage those in your practice, the patients in your practice, to come and be vaccinated. It's a great way, and it's what we need to do to protect ourselves. So thank you very much. I hope that that was a quick summary and showing that COVID vaccine for children is effective, doesn't have side effects, and we need to encourage it.
Thank you so much, Ian. I'm sure there'll be lots of questions at the end. We'll now hear from Dr. Freya Dib. As many of you know, Dr. Freya Dib has a practice in Canterbury. She sees many families in the Canterbury area in her practice, and she's going to tell us about her experience of addressing some of the issues and concerns families have expressed around testing and vaccination. Thank you, Freya.
Thank you, Luann. I'll just share my screen. Okay, I'd also like to begin by acknowledging the traditional custodians of the land of all of our current locations and pay my respect to elders past, present and emerging. My name is Freya Dib. I am a GP working at Lakemba and Greenacre for many years. Like many of you, I felt a need to take a proactive role in the community to help minimise COVID-related harm in our diverse communities. In collaboration with Sydney Local Health District, the PHN and local community organisations, I have been involved in several initiatives aimed at improving access to information and vaccination, particularly in the CALD communities. Thank you to the team at Sydney Local Health District, Dr. Teresa, Central Eastern Sydney PHN, and all those involved in organising this webinar for GPs. Welcome to all the GPs who have joined us tonight. I will be focusing on this issue from a GP perspective and welcome your comments and questions. Please feel free to write them down in the chat box or ask them at the end. Some of this slide, there's some overlap with Dr. Chi's presentation, but I'll just quickly go over it. Hopefully it won't take too much of your time tonight. As Dr. Chi mentioned, the high spike in new COVID cases being in the 0 to 19 age group, and that's expected because the under 12-year-olds haven't had access to vaccinations yet. COVID-19 infection in children poses a number of issues and concerns, including increased risk of recurrent disruption to schooling, recreational activities. School-aged children have had substantial absences from face-to-face schooling over the last 2 years. This has undoubtedly impacted the entire family unit, with parents needing to take time off work to provide support with remote education. The social and the economic impacts are significant, and we need to try prevent any further disruptions to schooling. Even with the RAT being implemented at school with the Test to Stay program, some parents may still prefer to keep their children at home for the isolation period after an exposure at school. There's an increased risk of transmission from children to elderly and vulnerable family members, such as those with underlying medical conditions or with a compromised immune system. As Dr. Chi also mentioned, there's that small but significant risk of multi-system inflammatory syndrome in children. There's a small risk of long COVID, which may cause further and prolonged absences from school. There's a small risk of serious illness in children and hospitalisation. Another complication, and Dr. Chi did also mention this, is that if we continue to have cases at schools, we may not give the opportunity to children with serious underlying medical conditions and weakened immune systems to return to school safely. Some of them have been keeping away from schools, and some parents have made that decision in collaboration with their GP and specialists because the risk of them returning to school when schools reopened was too high. So they decided just to stay off for the remainder of the school year. But if we continue to see increasing numbers in schools, those children unfortunately won't have access like the rest of the children to face-to-face schooling. So what are some of the challenges that GPs are facing with regards to COVID-19 in children? As GPs, it's extremely important that we continue to be vigilant with identifying new cases despite the easing of restrictions and the transition into the phase of living with COVID. It's particularly important now with the new variants emerging, as we're still learning about their risks. Some of the challenges and issues that GPs are encountering, which may be also contributing to the increase in COVID cases in children and adolescents, include the reluctance of some parents to have their children tested, as they believe their children are low risk of contracting COVID if the adults in the household are all vaccinated. The messaging prior to kids returning to school was reassuring, and we were all encouraging, the kids that it's safe and it's time to return to school. The messaging predominantly focused around that children don't spread COVID-19 to each other, but rather transmission occurs mainly from adults, so a teacher to a student. This was accurate at the time from the information available. However, we had limited information and children were absent from school for a prolonged period of time. Unfortunately, some parents are still complacent and they're relying on that cocooning effect of parents and teachers around them being vaccinated. GPs need to remind parents that students transmitting COVID-19 to each other is a real possibility, especially amongst the unvaccinated children. GPs should consider swabbing all children, obviously with permission, who have any COVID-19 symptoms, and remind parents not to send their children to school until all symptoms resolve, regardless of a negative test. Parents are requesting letters, sometimes stating medically fit to attend school, despite having some symptoms. There is some confusion with parents who have children that suffer, say, from asthma and hay fever, allergy type of symptoms. They sometimes request certificates to avoid frequent testing and absence from school. Unfortunately, this is tricky for a lot of us and schools to manage, as an assumption that chronic symptoms are due to another underlying medical condition can be unsafe. Also, managing those children, as I mentioned earlier, with the underlying medical conditions and making sure that they have an opportunity to return to school safely. And another challenge is working out the timing that they should be vaccinated. We want to make sure that everyone does have access to vaccination and also returning to school. So one of the major challenges for GPs, and I'm sure you'll all agree, and health professionals has been addressing the misinformation regarding COVID and vaccinations. I'm sure the majority of you have spent much time educating, counselling, supporting patients on COVID-19 and in particular the vaccinations. What is the role of local GPs with regards to protecting families and younger people? GPs have and continue to play an essential and significant role in COVID-19 vaccination, both in adults and children. Many parents have preferred to access their usual GP as they are often the most trusted family health professional, particularly for parents with children that have underlying medical conditions. We've found that trust in medical information and access to trusted health professionals has been a significant factor with vaccine uptake. GPs need to be comfortable with providing accurate information on COVID-19 in children, including the safety profile of the vaccines and common side effects, as Professor Caddison just went over. Common questions, but obviously this is not exhaustive and not limited to include vaccination concerns about fertility, changes to Menzies, risk of pericarditis, myocarditis, risk of allergy anaphylaxis, particularly in those children who do already suffer from allergies, from other allergies. Another common concern, which is valid from parents, is there really a need for their children to be vaccinated, given that COVID-19 in children is very mild or asymptomatic? It's important that we are confident in answering the concerns of parents and direct them to accurate and reputable sources of information. Whilst many adolescents have accessed the mobile vaccination clinics, the state hubs and GPs, there are still more than 1 in 3 children above the age of 12 that are unvaccinated, and GPs play an essential role in providing an opportunity to have these children access vaccination. So what are some of the ways that we can further facilitate this? Many GPs in the Canterbury area have taken a proactive role in COVID-19 vaccination in children, and this has contributed to the very rapid increase in vaccination rates in this age group. We still have some more work to do, particularly in our area and particularly before the start of the 2022 school year. Some of the strategies used in general practice to offer COVID-19 vaccination include inviting a discussion about COVID vaccination when a child presents for an unrelated medical issue. It would be similar to reminding parents about routine childhood other vaccines and other screening developmental checks, for example. Recalling adolescents 12 to 15 and soon the 5 to 11-year-olds through the practice software database, and providing opportunity for patients to book in for a vaccination, consult, whether that's through telehealth, telephone or face-to-face, using the interpreter services where necessary or utilising bilingual practice staff, using COVID-19 vaccination posters in multiple languages in the waiting room, focusing on accessing the CALD communities as they often have greater barriers to accessing healthcare in general. During the COVID-19 pandemic, many GPs and health professionals have collaborated with their local community and religious organisations to provide education and support in the forms of webinars through social media, local radio, and other platforms. This has been successful in providing information and vaccination access to some groups of the community that face barriers accessing mainstream services. Also, don't forget to encourage parents to engage with their children and adolescents and allowing them to participate in the discussion and consent. We often underestimate the ability of even young teenagers to make informed decisions. I've had many teenagers come into my clinic and attend with their parents, but that have asked their parents to wait in the waiting room while they've had their vaccine. It does empower them and gives them some autonomy. This list of resources is by no means exhaustive, but I found it really useful in my practice and some of my colleagues, where we just have a list of accurate and reputable sources of information that we can hand over to parents, because the community and parents were just drowned with a lot of misinformation. It's no wonder why some parents are hesitant and have concerns about vaccinating their children. The Sydney Children's Hospital Network has excellent family-friendly information and videos on COVID and vaccine safety. They've also got many resources for health professionals. The Central Eastern Sydney Primary Health Network also has a lot of information on all matters related to COVID, including the health pathways for COVID management. And of course, there's also the National Centre for Immunisation Research and Surveillance, which answers all the common concerns about vaccines. I would like to end by saying thank you for taking the time to join us tonight. We'll welcome all your ongoing contributions. GPs will continue to play a pivotal and challenging role in protecting families and younger people from COVID-19 complications. There's no doubt that the collective effort has increased vaccination rates and minimised COVID-related harm. It is imperative that we empower ourselves with the updated, accurate information to enable our patients to make those informed decisions regarding vaccinations. GPs will no doubt take the lead with the 5 to 11-year-old COVID vaccinations to commence, I think, on January the 10th, 2022. Keep up the good work. Thank you and take care.
Thank you so much, Freya. That was terrific. Now we're going to move to the question and answer session. But before we do that, can I ask for all the panel to turn their cameras on? And I also wish to acknowledge that Dr. Teresa Anderson has joined us. Hello, Teresa.
Hi, everyone. And I won't turn my camera on, but I would really like to just thank everyone for the amazing work that you've done over the last 22 months, nearly 2 years, to keep our community safe. And I am just so grateful to each and every one of you for the great leadership that you've been providing in our community. Dr. Freya in particular has been working just side by side with us, but we would all be in a very different place if it wasn't for all of you. And going forward, we just all need to continue to work together. It is amazing work, and you know, we really want to make sure we're protecting our children, and we really will be relying on you to provide that leadership, as Dr. Freya said. This is a really critical time for us, and I'm really grateful to the PHN for your leadership as well, and for organising this webinar. So thank you very much, Luann.
Thank you, Teresa. The panel members, would you like to turn your cameras on? Have you all turned your cameras on? Thank you to the speakers. Bertha, we can't see anyone online, can we? We can't ask people to turn their cameras on.
No, but they can turn their cameras on. If they just raise their hands, I can unmute them.
Terrific. Thank you very much. Okay, so we've got one question that's in our from Brendan Goodger, but before we start that, to just frame the questions as well. So we would also like to hear from you any questions you have of the panelists and the speakers, but also any ideas or early plans for local pharmacies and general practices to deliver the paediatric vaccines. What do you think would work best for the community and also those hard to reach groups or difficult to reach groups, and how can we all work together? So initial questions, Brendan posted, Professor Caterson, how long will the child vaccinations last? And when will my child need a booster?
We don't really know that yet. And one of the issues with COVID vaccination is we know that vaccination produces antibodies and killer cells. And we do know that they go up and then they slowly come down over time. But yet we don't know what level you need for protection. You know, so when it comes down, how low can it go, but you still have protection? Now, we're actually doing the study here in Sydney and Sydney Local Health District and Western Sydney to look at the longevity of the immune response, including the neutralizing antibodies, which are the ones that actually remove the virus. So we'll be able to tell you that in a little while. There is no data about that yet in children, Brendan. I'm sorry that we don't know, but vaccination is good. And if you ask me, I think we're going to need regular boosters, just as we do with flu vaccine.
Ian, do children get long COVID?
Yes, I think they probably do, but we're not really sure about exactly what is long COVID. There are a range of issues that might be considered long COVID. So when you look at those who've been in ICU and on ventilators or even ECMO, their lungs are damaged, and their lungs remain damaged for at least a time, and we don't know how long. Then there are other issues with long COVID, the fatigue, the post-viral type syndromes, and we're not quite sure about how long they last. We actually are starting a long COVID clinic in the district, and we are starting with those who've been admitted, so we can start with those with the respiratory problems, and the plan is to see how long these issues last. Again, at Children's Hospital, Westmead, they have about 400 children that they're following in this sort of way. So we will know more about long COVID in a little while. It's a bit of a difficult concept at the moment. We're trying to define it because it will have a range of different components: respiratory, post-viral, mental health, and we've got to sort those out. So children can get it, but we don't exactly know how long it lasts or what are the specific components.
Terrific, thanks, Ian. I'll go to another question, not yours again, Brendan. I'll go to Nada Andrick. Just wondering about your thoughts on why the 12 to 15 rates are low. Certainly our practice avoided Pfizer application due to the immense toll AstraZeneca took on our staff, and we have just started boosting. Is this similar for other practices, or do you see that a school-based rollout is needed? I'll leave that open to all of you. Any thoughts on why we think it's low in the 12 to 15-year-olds?
Certainly there are hesitancy issues, can I say, because I get rung by parents with a range of issues about vaccinating their children. And I think that we just need to educate and talk to the parents as we see them about the need for their children being vaccinated, both the 12 to 15-year-olds. And in fact, the man who comes to service my ornamental pond rang me the other day in discussion about his 12-year-old and his 15-year-old. And he had some misinformation that had come, and we were able to work it through. And I think that's really an important task for GPs in the community, because we really need to support parents and inform them.
Thank you. There were some comments about fertility issues at one stage, and I know some GPs raised that in discussions.
Joanne, we've just got a couple of raised hands. Renee, are you able to turn your microphone on?
Yep, I think it's on. Can you hear me?
We can hear you. Go for it.
Great. Yeah, so I'm from Sydney Local Health District. I'm just interested to hear from Dr. Freya and the PHN and any other GPs who might be on tonight, if they're anticipating that in early January, when the vaccine becomes available and the supplies are through to general practice, are you anticipating that there will be a demand in the local community, or do you think we need to be thinking about other strategies about how we work together to get good uptake in the community?
Hi, Renee. That's a really good question. There's certainly a demand, because we're already influxed with questions regarding when we will start vaccinating the under 12-year-olds. I think parents, a lot of them are at their wits' end with regards to the long absences from school, and they've now realised the importance and the role that childhood vaccination plays, not just for schooling, but for the wider community. And as Dr. Chi mentioned, a lot of the families in the Canterbury Bankstown area live in multi-generational homes. So it's not uncommon to have 10 up to 15 people in, a big home. And so there are risks, of transmission to vulnerable family members. So I think there will be quite a strong uptake in general practice. With regards to the previous question on why, the rates are low, I think that is multifactorial and partly due to what Luann mentioned, that there are concerns on the developing children and teenagers and what are the long-term unknown impacts. And also with regards to other, Renee, you mentioned other ways to try and improve the uptake in children. With regards to school-based programs, I know there was some backlash with a school in the West who did try the COVID vaccinations at school. There was quite strong backlash from parents protesting outside the school, and it was around the HSC time as well. I'm not sure how that would go with our local communities. I think GPs will continue with the children to play the major role with the rollout in this age group. And that's because there's that trusted long-term relationship, and a lot parents tend to have more concerns with regards to their children, and they do want to ask their trusted health professionals who know their children's history, particularly those that have underlying medical conditions.
Thank you. Bertha, are there other people?
We do. Rachel, can you turn your microphone on?
Hi, can I check that people can hear me?
We can hear you.
Great. Thank you everyone for a wonderful presentation. I'm Rachel Walker. I'm the Acting Director for Child and Family Health Services in Sydney Local Health District. And Dr. Freya, you talked about how some parents have been requesting medical certificates for their children who may have asthma or hay fever and may present with some chronic symptoms. I guess that's a question that's been coming up a lot for us within our child and family health services, where we have been able to bring children in for those face-to-face appointments and having those discussions with them around why we can't have them come to an appointment when their child is symptomatic. I guess I would just be interested to hear a little bit more from you around how you've tried to navigate those conversations and any other recommendations you might have.
Great question, Rachel, and it's extremely challenging and it happens on a daily basis, and we talk about it amongst our colleagues, and there's obviously no template for this, how to deal with this kind of situation. And it's just about having those honest and frank discussions with parents and just reminding them of the real risk. And basically it's just working out what their usual symptoms are, and if there's absolutely any change, even if it's a slight change in their usual asthma or allergic rhinitis symptoms, for example, then they really must be staying away from school until those new symptoms resolve. There's a lot of pressure on GPs to give those certificates and state that the child is okay to have a cough and attend school and have a runny nose and attend school because they suffer from allergies and asthma. We are extremely reluctant to provide those certificates at this point in time. That may change in the future with, vaccination rates increasing in younger children. But at the moment, it's extremely difficult, and it would only be really in a situation where there's been a prolonged absence and there's been a negative COVID test in that situation. We'd always request a negative COVID test if we were going to provide a certificate to get that child back to school, but it would mean that they would be having, regular COVID tests to stay at school if they continue to have symptoms related to their underlying medical conditions.
Thank you so much. That's great.
Pleasure.
Thanks, Rachel. Thanks, Ray. There is emerging data. This is another one in the questions. There is emerging data about males 15 to 25 and increasing reported rates of pericarditis. Are the younger age groups expected to be also similarly affected? Is there value in a rapid access clinic for adverse effects manned by experts in the field?
So can I just answer initially? The peak of the pericarditis is around 20 years old, and this actually came from data from the American Army, who vaccinated their young, fit men. And it appears from the data so far, and I was trying to show that there is a peak at about the 20s, and it drops off both ways, both ages, as you get older and as you get younger. And in the major study from Israel recently, the rate of myocarditis, pericarditis, to about 2 per 100,000. And this is sort of a little bit more, but much the same as occurs with many other vaccinations. And the myocarditis, pericarditis tends to be mild and recover within 6 weeks. So yes, we need to recognise it. 2, there needs to be a referral system to people who can assess and look after these people, and we're happy to have that. And 3, we need to say it is not a major issue, certainly appears for the younger people at the moment, and we can deal with it.
Terrific, thanks, Ian. You need to answer Brendan's question. Karen, how do schools classify students as close contacts? You're on mute. Thank you.
Sorry, thanks. So it depends on the exposure duration. It's actually the Department of Education that first gets notified of either a student or a staff. That's a case. They then go through the movements of the case during the time when the case was infectious at school. So who they saw, how long they saw the case, how long they saw the contacts for, what were they doing at the time. So, for example, if they were in a classroom for between 9:30 to 3 p.m, then obviously everyone in that classroom is a close contact. Everyone else that was not in that classroom and had no other exposures to the case would not be classified as a close contact. And schools are doing everything they can, obviously, to minimize people or, either students or teachers being classified as close contacts, either through cohorting of years, making sure that different years don't mix together in the playground during breaks, that sort of thing. But basically, it's dependent on how much time the contact would have spent with the case.
Great, thank you. Any other hands up, Bertha?
Not at the moment.
No. And I realise we've gone over 7 p.m, but I think it was important to get those questions in. And thank you, Nada, for your observations too about the differences in the vaccination rates, etc. It is interesting. And you said it's probably affected by no international students being counted. That's so true. We've been saying that for a little while. Very good. Any other comments? Brendan, did you want to make a comment?
No.
Okay, so no other hands up, so I think we will close. I wish to thank very much our presenters tonight. Dr. Freya Dib, thank you so much. Lovely to see you again. Freya's been talking about the pop-up clinic at the LMA, and Freya was there consistently, weren't you, Freya? And it was just wonderful how it evolved over time. Dr. Karen Chi, thank you very much for attending tonight. It was a great presentation. And of course, Professor Ian Caterson, who always gives us such great responses. Now, if there's any further questions, should we get people to direct it to the PHN, Brendan, and then you can pass on to us?
Most happy to do that.
Yeah, okay. So thank you, everyone. Teresa had made her remarks before, and we all wish to thank all of you for attending tonight. I think it's been really informative. And together we can get the vaccination rates up. I think that's the important part, that everyone plays their part in this. So thank you once again. Good night, everyone.